Okay, and you saw the brochures that we sent.
Yep. I looked through those. I saw the cases in there. Pretty cool.
Okay, awesome. Yeah, tell me
Mm.
what you like in those.
Well, just the facial development was awesome, and seeing, I'm trying to remember which number it was, but there was that one where the patient had a ton of crowding, and then the teeth were all nice and aligned with, it sounded like with just the appliance, not even any actual ortho at that point. So I thought that was pretty awesome.
Yeah, yeah, yeah. So these are two different airways.
hmm
Crowded teeth, impacted wisdom teeth. Wisdom teeth were removed, but you see how narrow this is.
Absolutely.
This is fully developed jaws, all the wisdom teeth fully in, and how wide and open this is. Just a
Crazy.
huge difference. This is actually a gold medal Olympian right here.
Oh,
So,
wow. Huh.
so his ability to breathe and get oxygen was probably a major advantage for him. People who have to perform and get oxygen, if they have good airflow, they're gonna do well, right?
hmm
So there's a lot of different systemic health issues that are correlated to sleep. With your kids, what do they have going on? What are the symptoms and stuff that you see with your kids?
Bedwetting, restless sleep, multiple wake ups per night. Um, my 5-year-old wakes up every morning and says, "I'm so tired," and she has a lot of behavioral issues. She's actually really smart and doesn't have the learning difficulty side of things, but she is basically always just this far from melting down. Those are the
And
main things. The little one, it's she doesn't have as many of the symptoms, but she's a thumb sucker and has the really narrow upper arch and the flared out front teeth and the um, trapped lower jaw, kind of a class two sort of thing going on. And she, well, she's also a mouth breather for sure. I'm not sure she can even close her lips without massively pulling them down because of the way her front teeth are flared out. So, yeah, all
okay.
those things.
hmm
Oh, nightmares is another thing for the older one. She has tons of nightmares. Like pretty much every night she has major nightmares.
Are you serious? Oh my
Yeah, it's
goodness.
really bad.
Okay, so she's got nightmares, bedwetting, not getting fully rested, tired, sleep deprived,
hmm Behavioral issues.
behavioral issues.
Yep.
This is gonna
Um,
make such a big difference.
I'm excited about that. Yeah, a good night is when she comes and gets me 2 times. Sometimes it's as many as
I used
three,
to,
5. Yeah.
oh
And
wow.
whenever she comes and gets me, she almost never needs anything. It's just comes into our room, wakes me up. I have to go tuck her back in, and then she's fine. So, but usually it's after a nightmare or a night terror or something like that.
Okay. Yeah, and with my kids, like, so I've been doing this a while, but my youngest was 2 when I started treating her.
Oh,
And it
nice.
seems like, so she woke up like clockwork at like 11 p.m. and 2 a.m. every
hmm
single night, just like clockwork.
Yep.
With
Eh,
my oldest daughter, like my wife and I, we have 5 kids, but my wife
nice.
and I would get upset at each other and we'd argue about it because I'd say, honey, she's too cold. She needs a warmer blanket. She's like me. She
hmm
runs cold. Warm pajamas. And my wife would say, no, I'm her mom. I've got the maternal instincts. She's gonna be too hot with all that. So she'd keep like
uh-huh.
the light blanket on, and I'd be like getting up in the middle of the night, like, I'm telling you, she's too cold. Like, right. So after a week or 2 of
Uh,
this, my wife would finally say, fine, you put her to bed. Do whatever blankets, whatever pajamas you want to do. You put her to bed.
yep. And she still doesn't sleep good, right?
And then she's
Yeah.
still crying all night.
Yep.
And then my wife's like, see, I told you.
Yep. I
And I'm
know how
like,
that
she's
goes.
hungry. Nurse her again. She's not
Uh-huh.
hungry. Yes, she is. I'm out of milk.
Yep.
Like, what? Swaddle it. We tried swaddling her. We tried all.
Oh man, it's frustrating when you just don't know what's going on and you don't know how to fix it and you can't without. Yeah, I know
Right.
exactly what you're talking about.
And so this was when I was in dental school.
hmm
And when I was in dental school, I was all about the premolar extractions. I had no clue about what we're going to talk about today. I had no clue,
Yep.
right? But my youngest, so then I started treating my other kids, when they were kind of mixed dentition, 7, 8, 9.
Mm-hmm.
But then, like my 5-year-old at the time, like you don't treat all primary dentition. So back then, nobody treated all primary dentition. It's like wait till they're in
Really?
mixed dentition.
Huh.
Wait till the permanent first molars are in. And I was working, so at this time I was doing airway. So I've done 2 residencies in airway orthodontics, and I've done all the trainings on any course out there. I trained on it. And everyone was like, no, you can't do anything in, all primary dentition. And
Oh man.
it's like it won't work. And I was like, I took that as a challenge. I saw what a
Uh-huh.
difference it was making. I saw how important it was. It's like, why not? And the thing is, my 5-year-old was wetting the bed twice a week, every
Oh
week.
man. Mm. Mine is every single night. I think she's had 2 nights in her life that she's been dry.
Are you
So
serious?
every single night, yeah.
So
Hmm.
she's in some kind of nighttime
She's in
thing.
diapers. Hmm.
Okay,
Yep.
so we didn't wait. So he was potty trained, and it was like, twice a week. But my wife was like, we kept having most nights he wouldn't, but 2 out of 7, and so we
Mm-hmm.
didn't. I don't know. I don't know why I shouldn't just put him in diapers. I don't know. That's not my department. All I knew was she was very frustrated and super upset. She'd be angry at him. She'd be upset cleaning the bed, changing the sheets. You know,
Mm-hmm.
I don't know why she never got the diapers. I'm gonna have to ask her. I don't know why I haven't. So, anyway, but that was why I was like, it wasn't about him having crowded teeth. It wasn't about his sleeping. It was about my wife not getting upset twice a week. That's why.
Hmm.
So I was making my own appliances in my garage, for years. And then I
Oh
started
wow.
hiring lab technicians and training people and doing them. But so me and my lab technician, we tried different styles and different models, and it was very, very difficult. The things that worked for the older kids were not working for the all primary. The primary molars
Mm-hmm.
are just too sloped. There's no undercuts.
Mm-hmm.
And so if you saw Michael's daughter's appliance, there's no clasps on them.
Mm-hmm.
So there's no metal clasp. So we and even with the appliance we had, we tried different designs and different ways of doing it. And so we figured out something that worked really, really well, very effectively, helped grow the jaws, and we're really successful with it. And now a lot of people use them. But with my daughter, when she was 2, so that helped us with the 5-year-old. But my
Mm-hmm.
daughter, who's waking up twice a night, 11 p.m., 2 a.m., it's like my wife and I were not getting upset at each other. We knew what was going on, right? So
Mm-hmm.
at this point, we knew it was her airway, it was her jaw, and we need to open her airway. But she didn't have enough teeth. So as soon as she got her first primary molars in, she had 16 baby teeth. We made an appliance for her.
Oh wow.
So you can treat like by 1.5 years old, if they have 16 baby teeth in, we can treat them.
Nice. Hmm.
So that's how we started her. And within 2 weeks, she was sleeping through the night,
Oh wow.
every single
Crazy.
night.
Before you even activated it, she was just wearing it.
Well, we started activating it.
You did
Yeah,
start
we started
activating it right away.
activating it
Okay.
right away.
Gotcha. Okay.
So her mouth's growing, but even with it in, yeah, we'd hardly activated it. I mean, 2 weeks of it's
Mm-hmm.
like no, but yeah, it's basically just wearing it. Yeah.
Hmm.
And what was amazing is when she started sleeping through the night, she's not potty trained, and she started waking up with a dry diaper every single morning.
That's amazing.
I
Yep.
I could not believe it. She used to have these diapers full wet, so wet, like it's like how are
Mm.
they holding it in,
Mm-hmm.
right? Just sock,
Yep.
it's like a
That's the
you know,
exact problem we have with they actually she has leaks a lot of nights because she pees so much. And yeah.
yes. Okay, so I want to get her an appliance, and I want to do another Zoom with you like in a month or 2 or 3, and I want to hear how she's doing.
Okay, sounds good.
But it was
And
so eye-opening for me with this whole thing. But when I saw that happen, that really increased my passion so much more.
Mm-hmm.
because I see that. But what we don't see is we don't see the effects on the brain development
Mm-hmm. Yep.
or on the older people, how the brain decline.
Mm-hmm.
Does that make sense? And I'll show you some things on the sleep study that I think will kind of translate on some of this stuff. So anyway, so about 6 months later, we wanted to put her in a new appliance. So we took her appliance out and we're having her sleep without it that night because I wanted fresh gum tissue. I
Uh-huh.
didn't want the imprint of the appliance. So no appliance that night. And when you know it, she gets up in the middle of the night, somewhere between 12 and 2, and comes in our bedroom and says, Mom, Dad, can I get my retainer and put my retainer back in, please?
Wow.
Yes, true story. She woke up in the
Uh,
night, came in and asked for it.
that's incredible.
It's like, so people say,
Mm-hmm.
oh, is my kid going to wear this? Is my 2-year-old, is my 3-year-old going to wear this? And at first, they don't want to wear it because they want tongue space and they want to breathe. And having something in, it's like at first, it's like the tongue wants to kick it out because they want to breathe,
Okay.
right?
Hmm.
But once they have it in for a little bit and they adjust it and they realize the lower jaw can move with it in, the lower jaw can move forward with it in, I can breathe better with it in, then they like it.
Gotcha. Huh.
It's pretty common. We get parents come in that say, you know what, it's really interesting that my kid will not talk to me while they're brushing their teeth because their appliance is out. They put their
Hmm.
finger up, they say, I'm going to finish. They put their appliance back in, then they'll talk.
Wow. Huh.
It's like they feel like it's good for them. They know it's good for them. You know what I mean?
Interesting. Hmm.
So, anyways, no, well, thank you for sharing that. Let's go back in this. So, are these kids healthy? So, what do you
No.
see with this kid's jaw development?
Retreated lower jaw, the kind of class two chin thing.
Yeah.
And I'm not good at spotting this yet, but I'm assuming the maxilla is probably deficient as well.
Yeah, definitely. Kind of thin lips here,
Mm-hmm.
kind of growing to a longer face, longer chin down here. Circles under the eyes a little bit.
Mm-hmm.
You know, this guy, you can kind of see his face, his mid face going in. His chin's out, but the teeth are being held back a little bit.
Mm-hmm.
You know, kind of tired look there.
That one is actually a lot like what my 3-year-old looks like. She's got the little teeth sticking out like that.
Okay, yeah. And that's
Mm.
holding the lower jaw back. So that lip
Mm-hmm.
posturing there is holding the lower jaw back from really growing forward.
Yep.
And so the thumb sucking in a way is like a splint. The thumb is actually supporting the lower jaw in an open airway position without straining the
Really?
jaw muscles.
Huh. I never thought about that. That's interesting.
Yeah.
Huh.
I know my oldest that my wife and I were always fighting over, like she
Mm-hmm.
was always sucking her thumb, and we put that disgusting stuff on her fingernail. We
Mm-hmm.
did everything we could to stop her from sucking her thumb. Nothing worked. She learned to like the taste of that stuff.
Oh no.
And it's like toxic stuff. I'm like,
Mm-hmm. Do you
but
find that getting a kid in an appliance is pretty effective for helping them to stop sucking their thumb too, then?
yeah.
Mm-hmm.
Yeah, I think it
Hmm.
really helped with it.
Interesting.
Yeah. So we'll have to see. I've never asked anyone specifically for feedback on that, but
Yeah,
maybe we can just make a couple notes to follow up with on when we do our follow-up call. Is that fine?
that certainly makes sense to me. Yeah.
Yeah,
Hmm.
so let's follow up on the bedwetting, if the diaper's still wet or if it's still like leaking at night, the behavior issues, waking up in the middle of the night multiple times, and for the younger one, the thumb sucking.
Hmm.
So, and there's a whole posture thing around this too. You know, so you see these kids like with the shoulder, this shoulder is a little higher, this shoulder's lower.
Hmm.
So, what's more important, oxygen or posture?
Sounds like a trick question, but I imagine oxygen.
Yeah. What's more important, oxygen or manners?
No oxygen.
So a lot of kids
Yeah.
will chew with their mouth open.
Oh yeah. Mm-hmm.
And the parents say, eat with your mouth closed, eat with your mouth closed. And when I get these kids that are really habitual mouth breathers that have a small mouth, I'll look right at the parents and I'll say, and if he's chewing with his mouth open, it's because he's got to breathe when he eats. If
Mm-hmm.
you're telling him, close your lips, don't chew with your mouth open, and putting pressure on him to do that, and he struggles and he chews with his mouth open, and that gets an emotional at home, be patient with him. He's just trying to breathe when he eats. And I've
Hmm.
seen I've seen
Interesting.
parents look really embarrassed and look at each other and be like, "How do you know?" You know, but as you start talking to parents and working with kids and doing this, you're going to see things and you're going to know who's chewing with their mouth open. And that's going to really build your credibility. And when they start hearing you tell them what's going on, it's going to help people believe that you know how to help them too.
Huh.
So a lot of times kids will like softer food because they're not doing a lot of hard chewing. And that's
Mm-hmm.
because there's less tongue space. And we'll go into the whole tongue
Oh.
space thing. See
Hmm.
if this will play a little video here.
Now he's holding it. Still holding it. He's trying to take. Now he's holding it. There he goes. Watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's gonna gulp again. There he goes.
Oh man.
Again.
So this is happening to kids every single night, Ryan.
Mm.
Yeah. And this is something that, over a lifetime, it's going to have a major effect on a person's quality of health and quality of life.
Absolutely. One thing that I was curious about, do you find that tonsils and that kind of stuff are a factor a whole lot, or is it mostly just development and that other stuff takes care of itself?
Tonsils and adenoids are definitely a factor.
Okay.
Yeah. So some of my patients will get them removed with the ENT. Some of
Mm-hmm.
them will do their jaw development and they'll get the nose breathing going. And our maxillary sinuses release nitric oxide.
Mm-hmm.
And the nitric oxide coming in the air helps to shrink the tonsils and adenoids.
Oh, okay.
So we've had, and
Hmm.
there's documented research out there that they shrink on their own too, especially with the nose breathing.
Oh, okay. Hmm.
So I leave it up to the parent. If you want to go in for an evaluation with the ENT, and decide with them. Some ENTs like to do it. Some ENTs don't like to do it unless it's like really,
Mm-hmm.
really severe.
Gotcha. I was thinking of uh, taking my 5-year-old into the ENT just to have him look and see if there was any structural things that needed to be dealt with. But I wasn't sure if that's something that you think should be a early thing, or if she doesn't respond the way we want to the appliance, and then do it.
So my tendency is to be conservative. If she's
Yeah.
stopping breathing for long time periods, I mean, we could do a sleep evaluation on her and see what's happening at night.
I've been with her for fairly long periods of time. I've never heard her snore and never actually heard her stop breathing.
Wow, so you've really done some detective work here. Like, what's
I'm
going
trying.
I love it. I love it. Okay,
Yep.
well, you're gonna love this. So yeah, I would
Hmm.
definitely start her on an appliance, get her going in the treatment, and let's see how she does. And at some
Okay,
point this year, next year, the next year, if you want to have those taken out, you could. But if we can really get her on a good program, it's definitely possible for those to shrink down on their own.
cool. I'd rather keep him if I can.
Yeah, yeah. In her body, not on the wall, right?
Yeah, exactly.
Yeah.
Yeah.
Yeah, that's great.
Mm,
Okay, so here's a lot of like the signs and symptoms of sleep apnea. So these are some of the things that we were just talking about.
sounds good.
Allergies is very common. Asthma is very common. I've had patients with asthma need to use an inhaler all the time to never needing you to use an inhaler again ever. And I never say I cure anything, but we try to help. I'm confident I'm going to do the best I can. We're going to try to have the best, results that we can. And physiology is complex. There's multiple factors for all these things, but it definitely helps with all these things. So down here, it's like underdeveloped jaws. There's soft diet is a factor, weak tongue muscles. Are you familiar with myofunctional therapy?
I know the concept and I've looked into it a little bit. That's something that I have a lot of interest in as well.
Okay. So that's definitely a factor. Low tongue posture, mouth breathing, excess sugar intake, all these things. So why is this all happening? So here's a model on the Bolton. This is called the Bolton norm with the forward jaw development. So we want to see the bridge of the nose down here with the lower of the chin, with the bridge of the nose and the mid face forward, all together in the same plane. The more these slope back, the smaller the airway tends to be. So 100 years ago and more, nobody had crowded teeth and nobody had impacted wisdom teeth. Are you familiar with that concept?
I am, yes.
Yeah. So here's a kid. Now we're getting, kids with crowding at younger and younger ages. So what are the chances of her being a premolar extraction case down the road?
Probably really high traditionally.
Yeah. I mean, she needs a premolar right here. This is a primary canine. Here's another one, severe crowding, and wait till the rest of her permanent teeth come in. How's it going to look then? This is getting more and more common.
Absolutely. I see it all the time.
Yeah. Here's another one with the permanent incisors erupting behind the primaries. Can you see that, or is the zoom in the way of that for you?
I can see it, yeah.
Okay. So here's a downward growth. So this is a big overbite, lower jaw trap back, and look at that gummy smile right there.
Yeah.
So the maxilla is down too far. So Dr. Coracini, he's done a lot of research and studies on all this about the soft diet. So when a primitive culture goes on the Western diet, the first generation, 50% of them will have crowded teeth. The second generation, 70%. The third generation, 85% of them.
Oh, wow. Huh.
So it's not a gene mutation, but it's an epigenetic effect of soft food diet and high sugars. So breastfeeding goes down, no sugar in the diet. So this is like, it's an acquired trait. It's not inherited per se, but we do inherit the epigenetics of this. So there's a whole diet aspect of it. Harder foods is better, but really, I think excess sugar is a very big factor. But all of these are factors. In addition, the myofunctional therapy and the nose breathing, the mouth breathing, that's another factor. With the sugar, 100 years ago, the average person ate 6 pounds of sugar a year. By the 1980s, it was over 150 pounds of sugar a year.
Whoa.
Yeah. So the average person gets 1 year's worth of sugar every 2 weeks now.
That's insane. Wow.
So every 4 years, we get 100 years worth of sugar in 4 years. And so I think this is one of the big factors. And there's research showing how sugar kind of dilutes the mineralization of the bones and the bones don't form as optimally. So I think this is a really, really big factor because I've had people, like I've worked with people doing myofunctional therapy since the 1980s. And the kids still have crowded teeth. So within the myofunctional community, there's kind of a perception that if we get the myofunctional therapy done at an early age, their jaws will develop and they'll have room for their teeth and they'll have a good airway. And I feel like myofunctional therapy is very, very important. It's an important aspect. It's a very important piece. But it alone will not fully develop the jaws and the airway.
Interesting.
Does that make sense?
Absolutely.
So, because I used to start with the myofunctional therapy and try not to do appliances, and I realize now I feel like that was a mistake, but I didn't know it was part of my learning process.
Uh-huh.
So the appliances are really good. Okay, I'm gonna show a little video here, and this is gonna kind of go into some of the stuff we've already talked about, but it's gonna be a review, and I really like how this was put together. Play this.
One thing
So,
real quick, I was gonna mention,
uh-huh.
one thing that we've gotten into in our office a lot here over the last year or so is oral probiotics.
Okay.
Like, I don't know if you're familiar with Probiora or BioGaia,
Yeah.
and there's some really great studies behind those.
Yeah,
But one of
which
the things,
one is it? Do you guys use mostly?
BioGaia and Probiora are the two that we use the most. And Dr. Mark Cannon out of Chicago has a lot of really good research on that. My hygienist is one of these people, but I've heard a number of people who have started taking the oral probiotics and say that the sinus congestion that they used to have chronically is gone. My hygienist, she was somebody who used Flonase every single day, and she started taking BioGaia in February of last year, and I think she's used Flonase one day so far since then. So it's
Wow.
been a really interesting thing how that seems to tend to clear up sinuses.
Wow, I love that. I love that. I would love for you to do a little 30 to 60-second little video testimonial with her sharing that. And I'd love to,
Sure, yeah.
we're gonna make an Airway Center page for you, and I'd love to put it on your page and use that to help promote your office and just bring awareness for everybody else as well, if that's fine.
Sounds good. Yeah, that'd be cool.
Yeah, awesome. No, thank you. Okay, so I'm gonna play this video and then we'll go from there.
Just a few hundred years ago, the human face was different. It was forward grown. Her wide profile and large dental arches ensured straight teeth and room for her tongue. Most importantly, she had plenty of space behind her upper jaw so she could breathe through her nose with ease. The modern face has changed. From childhood, her dental arches are less developed, crowding her teeth and giving her less space for her tongue, which impacts her airway. Many believe this stems from a number of causes, such as allergies that affect breathing. Another is the poor nutrition and softness of modern diets, causing toddlers to have underdeveloped chewing muscles and smaller dental arches. Because her upper jaw is too far back, she will struggle to breathe normally through her nose. To get more oxygen, she will compensate by opening her mouth to breathe, bringing her lower jaw down and back, creating a downswing of the face. This is how her undergrown upper jaw creates the appearance of buck teeth. She's actually compensating in order to breathe. If not corrected, the problem carries into adulthood. Extractions were documented in the 1600s as a way to treat crowding. Although they are a quick fix, they don't treat the problem of underdeveloped arches and have been implicated in harming the facial profile, making them the subject of much debate even today. Adulthood. In order to breathe, she will slouch her head forward to prop open her airway, creating a lifetime of neck and back pain. This is the infamous forward head posture. Having a healthy airway is crucial to the survival of life, and especially so during sleep. When muscles around the throat relax during sleep, a healthy airway stays open because the tongue is sitting forward and has enough space to be suctioned up against the fully grown palate. With underdeveloped jaws and dental arches, the palate is too small for the fully grown tongue, which is sitting back to begin with. When she sleeps, her tongue does not suction, rather it falls back and cuts off her airway. This is obstructive sleep apnea. Like crooked teeth, it's a modern condition. However, it can reduce life expectancy. Not surprisingly, obstructive sleep apnea is marked by the same traits that describe the headgear effect. Both jaws are grown down and back, creating a clockwise rotation in the lower third of the face. The myth of the overgrown upper jaw that needs to be held back has long since been replaced with science. Science has shown that young children can be buck-toothed naturally, and that the lower jaw catches up over time with a fully developed upper jaw. Essential to this is nutrition, the use of chewing muscles early on in life, and good breathing habits. This means breathing through the nose with the mouth closed and the tongue resting up against the palate. Also, the practice of maxillary expansion has been shown for over a century to correct crooked teeth and improve nasal breathing space. And since 1918, orofacial exercises have been shown to correct mouth breathing habits.
So here's our jaws. So from 2 years to 17 years is kind of how our jaws grow.
Okay, I
And
think that is in the brochure, right?
yeah, we had, yeah,
Using that. Mhm.
yeah. And in the brochure is like the jaws ideally grow forward more, but what's happening more and more is we're getting more downward growth.
Mhm.
So I've got that red arrow down, which is like, we don't want a lot of downward growth, but that's what a lot of people are getting more of. We want the forward growth. The more the jaws grow forward, the more room for the teeth. The more the jaws grow
Mhm.
forward, the more room for the wisdom teeth in the back. The more they grow forward, the better the airway.
Are you finding that a lot of the kids that you treat with these end up being able to have their wisdom teeth come in later?
It's definitely possible. They've got to be very
Okay.
disciplined and diligent. They have to, go through treatment and do their jaw exercises and do a lot of things. But, I had one kid that the orthodontist said he needed his premolars taken out and his wisdom teeth taken out.
Mhm.
And we treated him and his premolars were saved and his wisdom teeth were coming in fine.
Oh wow.
Yeah.
So
So,
you'd say it's a possibility, but not like a super high likelihood.
right. Yep. I put braces on one girl, and she lived like a few hours away from here. And
Mm.
she went to all these orthodontists, and everyone said, no, just get your wisdom teeth taken out. And nothing can be done. It can't be done. And she came to me and I brought it up into place.
Oh wow.
Yeah, and kept it. So it was like, I had a patient from Boise, Idaho. So I'm in Southern Oregon. So
Mhm.
Boise's like, I don't know, like 8 hours, give or take, or something from here. But 4 orthodontists said she needed premolars taken out.
Whoa.
And she heard about me from another patient and came out here and we treated her and no teeth removed. So I haven't kept in touch to see what happened with her wisdom teeth, but the parents were so happy how she turned out.
That's really cool.
Yeah. But by age 2, people's jaws are 55% developed.
Hmm.
Age 4, 75%. So it's like really this young age period, is really prime time to facilitate that natural jaw growth. This is when the kids'
Mhm.
heads are growing most. So then it's like 90% grown by age 12, and there's a little more after that, but it's really not a lot. So the younger we are to promote the natural jaw growth, the more it's going to affect the whole rest of the face and head.
Mhm.
So when one cranial bone starts to move, when the maxilla starts to grow and develop, simultaneously all the other cranial bones that are kind of connected to each other will start to change shape and change direction of
Hmm.
growth. So in some of my cases, you can kind of see things, which we can do things on adults, but on a growing kid, you can change the whole direction of their growth. So Dr. Christian Gimeno, he's a cardiologist in Stanford, and he came from England, I think, and he's doing heart surgeries on people. And back then they had like, I think the monitor, I think they had like a pulse ox. They had some basic monitoring equipment in the 70s. Nothing like today. But
Mhm.
people after heart surgery, like a lot of people died.
Huh.
And they didn't know why. And some had a lot of complications and some did well. So Dr. Gimeno had his nurses stay up all night around the clock almost like you've kind of done a little bit of with your daughter, right?
Yep.
So the nurses stay up around the clock watching these patients, and they reported back, just like that video of that little boy we saw with like the disrupted breathing and the disrupted airflow. They reported back that the patients had this disrupted breathing. They weren't getting air, and those were the ones having the complications.
Huh.
And so he realized, okay, this has something to do with the breathing, and these breathing disruptions during sleep is probably causing all these complications. So he was the first one to discover sleep apnea.
Oh, wow. Huh.
And he said, if we can help people breathe better without these pauses in breathing, they're going to need less surgery, less complications. They're going to recover better and all this stuff. So he defined obstructive sleep apnea in the 70s, created the apnea hypopnea index. Are you familiar with that?
I am. Yep.
Yeah. And he created the solutions. So in the 1970s, he used a tracheotomy to open the airway.
I guess that's one way to do it.
It was the only way to do it in the 1970s.
Wow. Huh.
Yeah. So if you had this breathing issue and you're going in for heart surgery, you need a bypass or whatever heart surgery, you got one of these. You open that little plug during the night so you can sleep and bypass the narrowing or the collapsing of the tongue, and then plug it up during the day so that you can speak and act normal.
Interesting.
And these people could never go swimming. They could never take a shower. This could never get wet, or there's a high risk of infection.
Mm-hmm.
In the 1980s, he developed the CPAP machine. So first they did trials and testing on dogs, then they started using it on humans. CPAP stands for continuous positive airway pressure. And the air pressure is a fan to blow the tongue forward to stop it from collapsing back. And then middle-aged people began using the CPAP, and today there's children on the CPAP machine. He said, if we can make room for the tongue and the mouth, we may be able to eliminate the development of obstructive sleep apnea. So looking at these, the straw or the hose, if you consider that an airway, which would you rather have in the back of your throat to breathe through?
Definitely the hose.
Yeah. And if you suck hard enough through that straw, the internal walls come together and it collapses. So here's the airway. Here's the normal breathing. Here's the narrowing. So if you imagine a river of water running down the mountain, when the river narrows, the velocity of water increases. When the river widens, the velocity of water slows down. So in the airway, there's a lot of space for airflow back here, and the air is going a lot slower. When it hits the narrowing back here, the air's got to go really fast past this one spot, and then it opens again and it can slow down. So that increased velocity right at this point creates a negative pressure or vacuum force that tends to pull the tongue back.
Oh, interesting. Okay, I didn't realize that.
Huh. And 70% of people with sleep apnea snore. 30% of people with sleep apnea do not snore.
Oh, wow. Huh.
But the tongue is getting pulled back, restricting the airflow, causing an arousal. Now, for the people who snore, the snoring gets louder and louder as the tongue keeps getting pulled back more and more, little by little, until someone wakes them up or they wake themselves up. The people who don't snore, they have the disrupted airflow and they have an arousal, whether they fully awake or just kind of toss and turn a little bit. There's an arousal that happens and they change position to start breathing better. So Dr. Remmers, he talked about the pathogenesis of sleep apnea and how there's a narrowing of the pharynx. He said obstructive sleep apnea would not exist if both jaws were placed properly forward in the face.
Oh, man.
So here's another story. This is just a short little clip about this kid's story and so many kids of what happens with them.
Hmm. And
So many kids struggle and have a hard time in school and all this. And when kids sleep better, they feel better. And when they feel better, they can do better.
yep.
Karen Bonnick, she did a lot of research, 11,000 children, making a strong link between sleep disordered breathing and diminished IQ.
Oh wow. Huh.
And, there's a lot about ADD, ADHD, but yeah, when we're sleep deprived, it's harder to focus and sit still. And you see the kids bouncing off the chairs that can't really sit still, and they're probably not sleeping great. So we use natural principles of bone growth and development to develop the jaws. Here's some other appliances. So this is the Myobrace. I was one of the first Myobrace certified providers in the country 10 years ago.
Nice.
And Myobrace can straighten the teeth without braces. A lot of times, if there's just kind of some mild crowding, if there's severe crowding, it's not gonna be as effective. But it does not develop the jaws forward.
Mm.
The Vivos came on as the DNA day and night appliance. Then Vivos bought them out like 5 years or so, give or take, and they rebranded it, but it's an appliance that primarily widens and develops the jaws. So this is the Vivos appliance. It's a lot of acrylic in the mouth,
Uh-huh.
and it has occlusal coverage there. But primarily people get a lot of width with this. And really, we want to get width and forward. We want to get the back of the tongue forward off the back of the throat.
Mm-hmm.
Just yesterday, somebody was in and she was thinking about getting the Vivos or getting my appliance. And so I showed her this. So this is after 2 years of wearing the Vivos appliance.
Mm-hmm.
So he's wider and he's got a little tiny bit of space behind those canines. There's a little bit of
Oh boy.
space in between those front teeth.
Mm-hmm.
So he came in and he came in to see me because he'd been wearing his Vivos for 2 years and now he couldn't bite lettuce off a sandwich. It just slid through the
Oh
teeth.
no.
Yeah.
Huh.
So he wasn't really sleeping a whole lot better. He still was struggling with his sleep, but he had a little tiny bit of space, but the front teeth were just kind of flared out a little bit.
Mm-hmm.
And then he couldn't bring his incisal edges together anymore. So it's almost like into a little anterior open bite. But he's got the width, but there's really not a lot of structural forward development or change on that.
No.
So go
When I
ahead.
was looking at pictures of them, it seemed like some were like this one you show here where it just had the screws pushing laterally and some had like a anterior forward segment. And I'm curious, was he in one like this picture or one that has the forward motion
Yeah, and
too?
this one has the forward
Oh, okay. Yep. Mm-hmm.
on that. So you can order whichever you want. So if you want to
Okay.
order a Vivos with just the lateral, you can. If you want to get it with the anterior segment. So the patient I had used the one with the anterior segment.
So it was using that too.
Yes, it was. It was using the anterior segment, and that's kind of what flared out those anterior teeth a little bit,
Interesting.
but it didn't develop the bone.
Mm-hmm.
So here's my appliance. Yeah, so here's the Vivos and here's mine.
Okay. Yours still has some acrylic on the palette, it looks like.
There's no acrylic here.
There's no acrylic there. Okay, I couldn't see. So that's the same as the sample ones that you sent me.
Yeah, that's right.
Okay. Sounds good.
Yeah. Yeah, and we'll go over some of that on the
Cool.
design. Maybe I'll just kind of share with you. So there's there's an angle. So there's an internal angle of the screw
Mm-hmm.
depending on the width. So if someone's super narrow, we'll angle these screws to widen as we go up and forward.
Okay.
If
Gotcha.
someone's got all the width they want, if someone's really wide, then we'll have these screws parallel to just go straight.
Makes sense. Okay.
Yeah, so if
So
we
you
want to just go
customize them.
straight, a little widening, a lot of widening.
Very
Right.
cool.
And then there's like an up down angle. So there's the vertical. So if this is in the mouth like this, if we set the screw up, it's gonna, if someone has a really, really gummy smile, we can get that back up and reverse the gummy smile.
Wow, that's cool.
Yeah.
Huh.
If someone's like got a big overbite, we can get a vertical and get that up and forward.
Nice. Huh.
If someone's edge to edge or anterior open bite or just a minimal overbite, then we'll just have it go mostly straight.
I see. Huh.
Yeah. So there's those angles, and then there's the occlusal thickness. There's different occlusal thicknesses. And then the amount of coverage on the teeth versus the amount of coverage on the palatal tissue.
Mm-hmm.
So if we're gonna try to get more upward, we'll want to leverage and have a little more tooth coverage and less palatal coverage.
Oh, okay.
If we want more straight, we'll have less tooth coverage and more palatal coverage,
Very neat.
or anywhere in between. So all those little aspects are things that I put in my patent application. So a few years ago, I've got a patent pending on this
That's awesome.
with
Very
those.
cool.
Yeah. So, okay. So then there's the orthotropics. So orthotropics is from England. John Mew started orthotropics in the 1950s. He's a premolar extraction case himself, and he started developing people's jaws and did a lot of learning and developing these appliances. So the orthotropics appliances, ortho means straight or correct.
Mm-hmm.
Tropics means growth. So orthodontics is straight teeth.
Mm-hmm.
Orthotropics is straight or correct or like ideal growth.
Nice.
So orthotropics is a system of getting like optimal or ideal direction of growth. And it's something like this appliance that's going to widen and push the front teeth forward.
Mm.
And you use that for 6 to 10 months or something.
Wow.
And then use this appliance to help the lower jaw develop forward. So
Oh, wow.
these little bars, the lower jaw has to come forward in front of those bars to close down all the way.
I see. Okay. So it's kind of like a little bit like a herps kind of idea or those sorts of things.
Yeah, something like that.
Mm.
Which like the Myobrace or the Vivos or what, like, they've got these appliances that you wear that kind of help to idealize the bite, and the upper and lower come in and they sleep with that in, and that helps the jaws kind of come to that position.
Mm.
And these can do really well, and sometimes I still use these and recommend these, but these are not going to help the jaws grow forward,
Gotcha.
but they're going to help where it is. Orthotropics is only done ages 7 to 11. So if you're younger than that or older than that, orthotropics isn't a system that's going to be predictable or that you could really use.
Okay.
And more people trained on orthotropics are going away from it because it's a pretty uncomfortable process. You can see the appliances are fairly bulky, like the Vivos appliances are pretty bulky. So here's our appliances. So these are custom made. So this one is lingual behind the canines. This one covers over the canines.
Mm-hmm.
So if there's a lot of crowding in the front or there's no space for the permanent teeth, we'll have it come behind the canines and it'll just open up a lot of space so that the front teeth can come in without crowding.
Mm.
Down here, there's already space between them if it looks like maybe there's already enough space, but we want to get more forward development of the mid face and help the lower jaw develop forward and open the airway. We'll get behind the canines and bring that whole front section forward.
Interesting. So basically, you're just putting the pressure on the palate, and it helps the bone to develop forward. Then.
Yeah, that's right. Yeah.
Okay.
So we'll turn the key on these twice a week.
Mm-hmm.
Some parents will turn the key like once a week or a half a turn once a week. Most patients do a full turn twice a week, every 3 to 4 days.
Okay.
Yeah. So this is a kid with it in. So it's got the smooth biting surface. So the slow pressure helps get things going forward. The smooth biting surface helps to stimulate the lower jaw to guide its growth in a forward direction. So when people bite, the lower jaw kind of indexes in against our upper teeth. Like we all have a
Mm-hmm.
bite the way our teeth kind of fit, puzzle piece and fit together. By having a smooth surface on that occlusal, we lose the bite. And so the body says, well, I've got to chew. And so if we didn't have that occlusal, it's like, I've got to chew, I've got to eat. Even though the upper jaw is growing forward, I'm going to stay here because this is where my bite is.
Mm.
When we take away the bite and give that smooth surface, the body says, well, I don't have to stay here. I don't have a bite locking me in here. I've got freedom. And so as the upper jaw grows forward, the lower jaw remodels and develops forward also.
So that's the reason why it has to be worn all the time then. So your body remembers to forget or whatever.
Yeah, exactly.
Yeah.
Also, the
Gotcha.
upper will relapse. So if you leave the upper appliance
Mm,
out, it'll go back. So it
huh.
takes like 6 months for the bone cells to fully mineralize
Okay.
and get a lot of stability. And so it's really like things like if you imagine pulling a rubber band out and waiting for that back end to come in fully, it's just a slow process.
Interesting. Huh.
Yeah. So one thing we use is we use the indicator line to measure from the tip of the nose to the incisal edge. And this is what John Mew started using in the 1950s. So the farther forward the jaws grow, the smaller that line. The more
Mm-hmm.
down the upper jaw is, the longer that line's going to be. So this is called the Bolton standard. So this was off like a genetic research study, I think in the 50s, about ideal facial development.
Mm-hmm.
And they tracked all these people, and the most attractive ones had the forward faces.
Hmm.
So back in the 1950s, sleep apnea was not around. It was not a thing until the 70s and 80s. But they were realizing for aesthetics, if people's jaws grow forward, it looks better.
Interesting.
And what looks better also functions better. If our faces
Mm-hmm.
are farther forward, we have less crowding and we have a better airway.
Makes sense.
But we have these lines that we can overlay over patients' faces. And I used to do that all the time. And I just got so busy, I don't have time to do it anymore. But I could show you that. It's kind of interesting to look at sometimes.
Yeah.
So this is a girl. It's like she's not doing too bad. She's doing all right here. She did not do treatment. And this is 2 years later.
Oh wow. Huh.
So as the maxilla comes down, the lower jaw rotates. So as the whole maxilla grows in a downward direction, right? Here's my
Mm-hmm.
TMJ, and the lower jaw can open and close here. So as the maxilla comes down, the lower jaw is rotating down and back. And so
And you end up
that's,
with a retreated chin.
yes.
Mm-hmm.
Yeah.
Makes sense.
So, and you see that, like, her upper lip looks almost the same, but behind those lips, the maxilla is going down. and the mandible's rolling back. And you can
Mm-hmm.
kind of see this is farther back. She's, got a little bit forward head posture there.
Mm-hmm.
This is the nose lip angle. So the higher the nose lip angle, it's an indication of where the bone is. Bro, if you do this profile photo smiling and you could see the bone, you want to have that bone at the 90-degree or less, not just the lips. So the farther back, the more down, the higher that angle, right?
Okay. Mm-hmm.
And then we have an echopharyngometer. This uses sound waves to measure the airway space.
Mm.
And people really like this. This is interesting. So without x-rays, this is like a functional breathing thing. And you can see how it affects them. And a lot of people use these for the oral appliances for sleep apnea in the adults. So here's a sleep study. So this is an ideal sleep study, 4 to 5 cycles between wake, here's the REM in the red and the light sleep here, and then the deep sleep on the bottom. So ideally we have 4 to 5 cycles of deep REM, deep REM, deep REM, deep REM. And with the disrupted sleep cycle, we'll have deep, kick out to light, deep, kick out to light, then go to REM, kick out to light, go to REM, kick back out, go to deep, kick up to REM, go back to light. So then this deep is broken up. So we call these disrupted or fragmented. So this is up to light, back in. So, because what's more important, oxygen or REM sleep?
Oxygen.
Yes. What's more important, oxygen or deep sleep?
Oxygen.
That's right. So
Yep.
our body's going to wake us up or arouse us. It's going to bring us out of our important sleep cycles into the light sleep because that's where we breathe better.
Mm-hmm.
So the red is the heart rate, the blue is the oxygen. So the instant, it's like within a 100th of a second, Ryan, there's a disrupted airflow. The heart is going to respond, the heart rate's going to pick up, and the sympathetic nervous system is going to activate, and the person's going to come out of their deep sleep or out of the REM sleep and go into a light sleep.
Wow, crazy.
So we see the second this comes down the tiniest bit, there's a little heart rate spike. Little drop in oxygen here, heart rate spike here. Little drop in oxygen here, heart rate spike here. There's one here and we see this here. Little drop in oxygen here, heart rate spike here. Little drop in oxygen here, heart rate spike here. Drop in oxygen here, heart rate spike here. Are these big drops in oxygen?
Not huge, no.
But if this brings someone out of the REM and deep sleep every single time that happens, is that going to affect their sleep quality?
Absolutely. So those little sympathetic shots are also bringing them out of their deep sleep.
Yes.
Huh.
I had a
Interesting.
patient come in yesterday. I'm going to tell you the story, but basically she has no cortisol during the day because it's all used up at night with
Oh,
all these
wow.
little arousals.
What kind of symptoms was she having from that?
Well, so this lady, she gets headaches every day. She's tired. She needs it. She feels like she has to take a nap every afternoon. Some people take a nap every weekend. I used to take a nap every single Sunday.
Oh, okay, huh.
And now I never do. Yeah, so growing up, my parents didn't know if I had narcolepsy or what. I fell asleep driving on the freeway twice.
Oh no.
Yeah, crashed on the freeway twice. Like I'm lucky I survived that.
No
But
kidding.
I did snore a bit and I was kind of tired, but it was just normal. Like I didn't know anything different. And
Yep.
I started treating the adult sleep appliances, but I didn't really have any severe sleep apnea or anything, so I never made a sleep appliance for myself. And I started treating these kids, and then I started opening premolar extraction spaces, but I never had premolar extraction spaces. But then as I started treating all adults, I'm like, and I treated myself, it's like my life changed.
Oh wow, that's
So
awesome.
instead of nodding off and falling asleep at church every single Sunday and feeling bad about it, like I don't get tired. I don't fall asleep at church anymore. Like I
Wow.
stay awake. I don't fall asleep on my wife anymore. Like I don't get drowsy driving. I don't have to pour water down my back when I'm on a road trip, or you know what I mean?
Yes, I do.
So
Yep. Very
it's had a
cool.
major, but so the lady, so she has daily headaches, her jaw clicks and pops. She wakes up around 3 o'clock every morning and can't fall back asleep.
Hmm.
Because what's more important, oxygen or sleep?
Oxygen. Yeah.
And if we start losing oxygen, the sympathetic nervous system would say, okay, stay awake. You're done. This is too risky. Stay awake.
Hmm.
And
Wow.
I've treated people with sleep apnea and I've treated with people with insomnia. And it is two sides of the same coin. We do the same
Hmm.
treatment and they both sleep better.
Wow.
But
That's
the people with
crazy.
insomnia typically have upper airway resistance syndrome. Give them 10 or 15 years and they're going to have sleep apnea. So here's a person with sleep apnea. So now we see the oxygen coming down and staying down for a longer period.
Hmm.
And there's no heart rate spike.
Oh, sure enough. Yeah.
So we're going back. So see how big these heart rate spikes are?
Yep.
Hardly any oxygen drop. And there's a huge heart rate spike on some of these. Huge oxygen drop and then hardly any heart rate spike. Every time this happens, the adrenals are going off, cortisol release. And over a
Mm,
lifetime, the adrenals start to go into adrenal fatigue and adrenal failure.
wow. Huh.
There's no heart rate response because the adrenals are worn out, the body's fatigued, now the oxygen stays down, and this correlates with the REM sleep cycles. And the REM sleep cycles is when our brains are cleared of the beta amyloid plaques that cause Alzheimer's and dementia.
Oh man. Huh.
So every time during the REM sleep cycle, this oxygen is down in the low 80s. There's no heart rate spike and it stays down and it comes down here. There's no heart rate spike and this person's getting Alzheimer's and dementia.
Wow.
So when we're young and healthy, our adrenals function, our sympathetic nervous system is activated, and we keep our oxygen up. So when you're telling me you're putting your pulse ox on and your oxygen is good, you're missing the rest of the story.
That tells you that my adrenal gland is still working okay too.
Yes. Yes.
Yep.
So you're young, you're
Mm.
healthy, your adrenals are working, but
Hmm.
it's taking a toll year by year, decade by decade. It's taking a toll. So here's a kid. This mom came in with this kid and she said, why is my kid having these nightmares and night terrors and these bad dreams? And I said, I think it's his airway. And she said,
Hmm.
I don't think so. He doesn't have any crowding. She said, like, I think he's doing okay. I think it must be something else. She left. She went to chiropractors, naturopaths,
Mm.
MDs, dietitians. She had allergy testing done, checked for food allergies, tried, whatever, like herbs, herbal remedies, like all these things she tried. 2 years later, she came back to me, and then I had this sleep monitor. So I didn't have this sleep monitor the first time they came in, and he didn't have any crowding, so she didn't believe me.
Hmm.
When she came back, she told me this research. She said, over the last 2 years, I've tried all these things, nothing has helped. And I do this research, and there's all this research about ADD and sleep disordered breathing. And maybe you were right. Maybe it is his jaws. And I said, well, I think I am, but I'm doing these sleep monitors now. Let's put him on this monitor and let's find out.
Hmm.
So 13 times an hour, every hour, he's in respiratory distress.
Wow.
Every 5 minutes, all night long.
That's crazy.
This kid's having these arousals, and his oxygen at the lowest was only going down to 93. That's not super low, but he's sleep deprived,
Hmm.
right? 14% of the time, his oxygen's lower than 88. 22 seconds, his oxygen is below 88. So he was getting down there. Guess this is baseline. Here's his duration on these oxygen numbers. So, I mean, he's going in the red here, right? He's in the red here. So he's got some issues. He's not sleeping good. So he lived out of the area. They drove 2 hours one way to come and see me. And we start him in his appliances. They leave. Like, I'm so interested how this is going to go for this kid. It was my first case where there was like a lot of big nightmares and night terrors. And, I hadn't seen a lot of cases with that. Like in my family, we didn't really have that. We had the disrupted sleep and the waking up and coming in the room, but not a lot of like tears or bad dreams, so to speak. So a week or two later, I call the mom and say, hey, how's he doing? What's going on? I left a message. She never called me back. A week after that, I sent an email. She never responded. A week after that, I
Wow.
sent a couple text messages, no response. And I'm like, I don't know if she threw away the appliance, if she was upset, if it wasn't working. Like I'm like, okay, but she's completely non-responsive, right? So about 3 months later, she calls to come in for an appointment. And I'm like, oh my goodness, they called, they're coming in. Like, what's going on? Like, I'm like, I got so excited. I saw them on the schedule. So they walk in, they sit down. I'm like, how are his nightmares and night terrors? What's going on? That was the first question I asked. And she's like, well, let me give you an update. Let's see. We've been wearing the appliance. We're turning the key about twice a week. Well, we've seen some good things with his jaw. Yeah, his jaws are going forward a bit. I'm like on the edge of my seat, right? Like, and she's like nonchalant, like she's like, oh, his jaws are going forward a little bit, and he's feeling a little better, and the ADD, yeah, that's going away, and his behavior's better, and good. So she talks for like 5 minutes, which felt like a half an hour, and she stops talking, and I'm like, what about the night terrors? Like, you didn't say anything about that, like the nightmares, like what? And she's like, oh yeah, those went away within the first week or two.
Oh man, that's crazy.
It's like it wasn't even on her radar anymore. She's like,
That's wild, huh? So cool though.
So yeah, we started treating his younger brother, like I think when he was like 4 or 5 or something. So, which a lot of parents say, why would I treat a little kid? Why treat a 2-year-old or a 3-year-old? And it's because the sleep, the brain development, the behavior, we want these kids to feel well rested and feel good, right?
Absolutely. Something that I'm not 100% clear on, how do you, in the people like say me, where you might see slight little drops in O2 sat, but compensating pretty good, how do you detect the sleep disturbances or whatever, that kind of stuff?
So we look at the REM and the deep sleep, how there's 4 to 5 patterns of deep and REM. And
Okay.
those are
How
really
how is that detected?
What's that?
How is that detected?
A home sleep test.
Oh, okay. So the monitor has a way of doing that.
Yeah.
Okay.
So it's
Gotcha.
with pulsed arterial tone, the muscles of the arteries, their pressure.
Okay.
So there's
I
heavy
see.
technology in these little sensors. So the people who have the phones that measure their sleep on their phone with different apps and stuff, those are an indication of a trend, but they are not diagnostic.
Gotcha.
The home sleep test monitors are like 97% as accurate as an in-lab overnight sleep test in the sleep center.
Oh, wow. Huh.
So more and more people are doing these home sleep tests that have a high rate of accuracy, and they really show what's happening with the sleep cycles.
Gotcha.
Yeah. And I can go more into that and show you some more examples on that too.
Sounds good. Perfect.
But yeah, so right here at age 2, we see the maxilla growing down, the lower jaw trapped back. We see the overbite. There's a lack of space. Is this jaw going to grow bigger? Is this girl going to have room for her permanent teeth? Is there any chance, a slight chance?
Well, I guess miracles can happen, but
No,
with that
so not
trapping, I don't
without
think so.
not without treatment.
Yeah.
But a lot of parents think, oh, I had a mom come in the other day that I saw this girl when she was like 5. And I said, she's going to have severe crowding. We could start her on our appliances. We could grow her jaw. And the mom's like, well, she's still growing. I think, I don't see any crowding. So now she's like 7, sees a regular dentist, and she's like, oh no, there's going to be major problems. You need to see an orthodontist right away. They go to the orthodontist. The orthodontist says, oh my goodness, this is major. You need 4 teeth pulled. And so she came back
Yep.
to me and said, okay, you were right. I didn't believe you 3 or 4 years ago, but I believe you now, right? But that's the oldest child, right?
Yep.
But when I do this on that first kid, now the younger sibling, is she going to believe me the first time?
Absolutely.
Yeah. So at first, parents aren't necessarily going to believe you, but be patient, because how many kids is that mom referring to me now?
Probably a ton.
Yeah. And so it's like, it's okay. Like, this is the first time people are hearing about this. Like, don't be too excited or don't be too passionate like I am, because it'll scare people away, right? Just
Uh-huh.
kind of nonchalant, right? But now in Southern Oregon, people come to me from this. I've had patients from 17 states and 4 countries come to me for this treatment.
Oh wow. Huh. That's really
All
cool.
word of mouth, no marketing.
Very nice.
And so it's like, I can be a little more aggressive with it because I've got the reputation, and we
Yep.
want to help you build your reputation and establish your credibility. But right at first, if people aren't listening or don't want to believe you, that's okay. Just say, hey, that's okay. Just let's see what happens. Let's see how little Johnny does when he gets older. Maybe everything will be fine. Leave it at that. You know what I mean?
Makes sense. Yep.
Yeah. But you're going to get parents who go home and, go home, do your own research, and they're going to find all this stuff out. And there's more and more information out there. And then they're going to come back in for treatment sooner and sooner.
That's
So,
awesome.
but we see all these back teeth are kind of inclined inward. So they're kind of all lingually inclined. Even the upper teeth are kind of lingually inclined, right? So that retroclination, we want to get those upper jaws up and forward. So this is like waking up twice a night. And then here to here with only the upper appliance. No lower
Whoa.
appliance was used.
That's amazing.
Because at this age, the lower jaw is already programmed to grow by itself. But if we'll unrestrict it, then it can grow. So here's a 3-year-old. His dad had headgear for several years during his orthodontics. Very retruded, has struggled with sleep apnea, migraines 3 days a week, practically on disability, can't hold a full-time job. And so when I showed him what I do, he didn't want to wait till his kid was older. He wanted to start at age 3. And so the parents who've been through retractive orthodontics, they're going to get this very easily.
Yep.
So, but no space between the primary teeth. What are his chances of crowding?
Very high.
Yeah. So here we go. Now, what are his chances of crowding?
Very low.
Yeah.
Yep. That's awesome.
So here he is from 3 to 5. So here's his bite. So when he's 3 and we say close your mouth, he closes edge to edge, but his bite was back.
Oh, okay.
You could see his lower behind. He's not end on end.
Yep.
But so many kids, they posture forward
Yep.
because they breathe better forward. And when I take my palm and push their lower jaw back and in to get a full bite, to get a decent photo for my records so I can have accurate records, kids go hysterical and they think I'm trying to suffocate them and kill them.
Wow.
So I don't do that anymore.
Yeah.
So we're gonna take these records as acceptable. But seriously, they do that because that's where they are 24/7. They only bring their teeth back to chew something really hard. Half of the time they're on a soft food diet, chewing edge to edge like this so they can still breathe while they eat. But as we develop him, and you see, we got him forward like 6 to 8 millimeters.
Yeah.
And look at this space behind those canines and all the anterior teeth. I mean, he's forward quite a bit. And his lower jaw He's not in some buck teeth position. His lower jaw came forward right with it. And now he
Very
can
cool.
bite normal instead of feeling like he's got a posture forward. So here's his profile. Tell me what you see.
Definitely less rotation down of the mandible, like you were saying. Forward growth.
Yeah. So you see that rotating downward, kind of that
Yep.
flat upper lip, higher nose lip angle, smaller nose lip angle, jaw coming forward, fuller lips. And we're kind of close to California here. Michigan, you're a little farther away from California. But we get a lot of people getting the Botox or the dermal fillers in the lips to give women puffier lips.
Oh yeah. Mm-hmm.
When really what they need is that jaw support supporting their lips. So here's his profile. And you can see his
Oh
teeth a
wow,
little
yeah.
more retroclined and they're a little more upright now. So if you do that nose lip angle to the bone and to the teeth, he's higher than 90 degrees and
Mm-hmm.
closer up to 90 degrees. Looking at the posture, so people go from a forward head posture to a straighter, more vertical head posture. So here's a 5-year-old, small lower jaw, head tilt chin lift. Why does he do a head tilt chin lift? So you see his head tilt chin lift.
Absolutely, yep.
And why is he
Open the
doing
airway.
that?
Open the airway.
Yeah.
Yep.
So headed toward crowded teeth, no crowding, better posture, stronger lower jaw. So this family, the mom drove 6 hours one way to come and see me
Wow.
because she heard I do something a little different. All the orthodontists wanted to wait until her permanent teeth came in crowded. She's 6.
Mm.
And I was pretty impressed with this mom, but we're able to get all of her permanent teeth in without crowding. Lower jaw trap back. You see the grinding pattern. You see the wear
Mm-hmm.
on those front teeth. Why is she grinding forward?
I assume airway problems.
Get the back of the tongue forward off the back of the
Yep.
tongue. Yeah. So here she is. Lots of room for all the teeth. Forward head posture, straighter head. So
A
many
huge
people have
difference.
neck pain. And this concept is a big part of it. We get so many people that say their neck pain's better. I mean, so here, ADHD, a little bit of bedwetting, but definitely behavior problems to like a model child, good kid, severe crowding, no bedwetting, sleeping better. So this is the same one. So that's the profile. Here's the smile. Downward growth pattern,
Mm-hmm.
maxilla growing down. We get it up and
Mm.
forward. So here's another one. We saw this one earlier, but downward growth pattern, severe crowding. The orthodontic program here just trains on headgear and extractions.
Oh man.
And so it's like, okay, let's start taking out the baby teeth, and then later we'll take out the permanent teeth.
Mm.
Right?
Absolutely.
So, and we do this. Is that a good thing for this girl?
Tons of space there now, yeah.
She needs room for this lateral. She needs a
Mm-hmm.
permanent canine, which the permanent canine alone will fill the rest of this space.
Yep.
And then she needs a premolar.
Mm-hmm.
What are the chances?
0.
But if we go over here, now what are the chances?
Great chances, yeah.
But you see the imprint on the tissue
Mm-hmm.
because she did so good wearing her appliance, bless her heart.
That's awesome.
She wears this removable appliance in and out, takes it out to eat. And after a year and a half, she's got plenty of room for all of her teeth, normal crowding, and here she is.
Wow, very nice.
Did we have an impact on the rest of the life of this girl?
Massive, yeah.
And here's her profile. Flat upper lip, high nose lip angle, jaws rolling back, forward jaws, fuller lips, rolling in, coming forward. Is this a good thing for these kids?
Absolutely, no question about it.
Yeah. So Ryan, when do you want to start treating your 2 kids?
As soon as I can get the appliances back.
Do you want to do one at a time or start them both?
You know, my older one especially is going to be really resistant to it. And so I was thinking if I get one for all three of us, then we can do it together. I think that would probably be a good way to do it.
That's a great. Yesterday we just started a mom and daughter. It's,
Oh, okay.
yeah, because when the kids see you doing it, they take to it so much easier.
Yeah,
Yeah.
I think that might be the best way.
The other thing we'll do is when kids have their appliance in, we'll give them blueberries or strawberries or something they like to kind of promote, like build on the positive and say, hey, when you're wearing this in, I know it's hard. And so we're going to give you something special when you keep your appliance in. And usually within a week or two, it's just in all the time and they're used to it and it feels good and they want it in.
That's the way she'll be once she gets used to it, but she's just very, very resistant to change. And so, um, yeah, it's getting over that initial hurdle that'll be a challenge, but
Yeah.
we'll make it happen.
Awesome. Awesome. What about your patients? When do you want to open this up to your patients?
As soon as I feel comfortable that I know what I'm doing.
Okay.
So
We want to get you
ASAP.
comfortable.
Yep.
We want to get you comfortable, Ryan. So we need to make a plan because we need to get with, whoever wants to on your team, like some front office. We can get some front office training on the talking points. We can get your assistant on the delivery and the fitting and the setup. Do you have an assistant in mind that you've talked with yet or that we could possibly work with?
I haven't talked to her about it yet, but I have one in mind that I think would be able to do this kind of stuff.
Okay, what's her
The
name?
Jana,
Jenna?
Janna.
Okay. Jenna, okay, so you talk to her first, but then once you get with her and she's on board, then I'd like to get my team with her and have
Yeah.
them so I'll show you all the stuff, but I would like to have my team get with her and do some training with her so that by the time you get your appliances for your kids, she can do the delivery.
Oh, okay. Sounds good.
So I want to build her confidence.
Hmm.
And I want her to feel like she knows what she's doing and she can do this.
Exactly.
Because I
Yep.
don't want it to take 2 or 3 years for you to build your confidence and know what you're doing. I want to give you 2 or 3 months
Awesome.
and get you up to speed and get you going and get those other operatories making money for you. So here's another case. What kind of growth pattern was she in on the before?
Definitely vertical.
Yeah.
Down. Yep.
Yeah. Downward growth pattern. Are her teeth coming out or coming in?
They're in.
Yeah. Lower jaw growing forward or trap back?
Trap back.
Yeah. Otherwise, she's a cute girl. Like she's nice, she's cheerful.
Yeah.
But give this another 2, 3, 4, 5 years with this downward growth pattern. Where's this gonna go?
Okay.
Better TMJ or worse
Yeah.
TMJ?
Definitely worse TMJ.
Better aesthetics or worse aesthetics?
I would argue worse.
And there's like personal preferences, right? But generally, when we can get this jaw growing better, it helps a lot of things. So here she is on her after. Broader smile, less gummy smile, and just super cute girl.
That's awesome. No kidding.
But getting her jaws growing, but I don't know if we've got her occlusals, but I mean, but we brought her forward quite a bit, like 8 millimeters, and her lower jaw comes with it, and this is just beautiful.
That's awesome.
Yeah, she would have easily been a premolar extraction case, and now she easily has more than enough room for all those teeth.
Very cool.
So this one, she came in for an evaluation, and I'm looking at her and palpating her
Oh.
muscles and doing my thing, and it comes out that she has headaches twice a week. And the mom's sitting in the room. She's like, "What? You do?" Like the mom had no clue that this girl was having headaches.
Really? Huh.
But you can see how she's like asymmetrical. Can you see that straight on? But it's like her lower jaw's pulling over. It's like she's got that crossbite coming on. So she's got this anterior crossbite coming on right here, and she's kind of locked in. So the lower jaw is stopping the upper jaw here, and the upper jaw is stopping the lower jaw everywhere else.
That's crazy. Yeah, she's locked in both directions, huh?
Both directions. So look at her spacing Is she gonna have crowded teeth?
Yeah,
Maybe or definitely?
I'd say definitely.
Yeah, definitely. She has no chance. Major
Mm-mm.
crowding. You can't tell
Yep.
she's a cute girl. There's no signs of crowding, but 100% she's gonna have crowding. But here's her before and after. You see that lower jaw kind of coming back a little bit. If we did not do treatment, this would have continued this downward direction. We got that coming forward more, and I think that was a nice thing for her.
That's awesome. Yeah.
So here's a typical premolar extraction case. 4 orthodontists around here all say take out the premolars. So this is no braces. This is one of our airway appliances developing this jaw. And what I tell parents is the canines are where they're supposed to be. Everything else is underdeveloped. We want to develop the bone out to those canines.
Oh, interesting. Okay. Huh.
I guess he had braces for 3 months. So my shortest on braces for a kid is 2 months. Some kids 4 to 6 months, but 6 months. But we're not keeping kids in braces a super long time.
Nice.
Okay, so this is the one, no braces.
You're basically just using the braces to do a little bit of final tweaking and aligning
Yeah,
rather
yeah,
than a bunch of serious moving.
yeah,
Do
yeah.
you see less issues with resorption and stuff like that with this method versus the traditional braces method?
Absolutely.
Okay. I figured
Definitely.
that'd be the case.
Yeah, 100%.
I have a sister-in-law who would have really benefited from this as a kid. I didn't know her as a kid, but she had the kind of the really retreated, all this stuff we're talking about. And she ended up having orthognathic surgery sometime in her early teens, I think. Um, and she had, of course, ortho at the same time as well. And I don't know all the details because it's before I knew her, but I know that they did upper and lower orthognathic surgery, and she had a relapse of that, and ended up going through braces again and orthognathic surgery a second time, and still relapsed again. And so she currently only occludes on second molars on one side, and anyway, there's a whole bunch of messed up stuff, and I think it probably has something to do with condylar resorption and stuff like that. She's not local to me, so she's not currently my patient, but it makes me wonder if she might have avoided all that stuff if she had just had this as a kid. I suspect she would have. Her maxillary roots are probably half the length they should be because of all the ortho she's been through. So it's really severe resorption going on too. Makes me sad.
Oh my goodness,
Uh,
that's so
yeah.
unfortunate.
Mm-hmm.
Wow,
Yep.
wow, wow, wow.
Uh,
Wow,
You just see.
if she wanted to, I mean, if your wife wanted to mention it to her at any time, if she wanted to connect with me, I'd be happy to get with her. And she might never want to go into a dentist's office again,
Mm-hmm.
but
I actually think she might be interested because I know she's been considering looking at readdressing it again, but she's very leery of going through orthodontic surgery a third time,
I,
and for good reasons you can understand.
yeah,
But it'd be interesting to see if any of this stuff could help her out now as an adult.
right, right. Yeah, absolutely. Yeah, definitely.
Hmm.
Wow. So with your wife seeing her sister go through that, she's gonna really appreciate this too.
Absolutely. Yep.
Yeah. So here's a class 3 case, just, mild class 3, but he doesn't need teeth removed. He doesn't need, anything, but we get him in his appliance and we just get the jaws forward and establish a really nice bite, really nice smile. Here's another class 3. So her mom had surgery for her class 3, and this little
Mhm.
girl came in and the dad was like, she's just gonna need surgery. Dr. Tanner's can't help her, it's not gonna work. The surgeon said that only surgery works to correct this, right?
Yep.
So, but she's pretty severe. Like
No
there's,
kidding. Yeah, that is huge.
yeah. So it's pretty severe. Here she is.
Wow. Very cool.
Yeah. So,
So
and
in those
we could put braces on and close up those spaces or do Invisalign, but they're really happy with this.
nice. In cases like that, uh, obviously I understand the lower jaw being trapped behind the upper. How do these work in relation to that kind of thing?
So the lower jaw, this is a genetic. So there is a genetic component, and our
Okay.
jaw growth is genetically programmed to grow. So people tend to have similar growth patterns as their parents, but accentuated. So I've been doing this since 2010, and I've seen 4 families where the kids have a bigger, more developed jaw than the parents.
Really? Huh.
Every other case, the kids have more crowding, more underdeveloped jaws, smaller jaw than the parent, and at a younger age.
Interesting. So in this case, you basically just help the upper jaw to do the growth it should have done to catch up with the lower one.
Yeah, we didn't do anything on the
Okay.
bottom.
Makes sense. Okay.
Yeah.
Neat.
So here you see this is in a downward growth pattern, high nose lip angle, lower jaw rolling back.
Mm-hmm.
I want to see the cheeks kind of parallel to the bridge of the nose. Let's see. Okay,
Oh,
so right here, I mean, these are almost flat. Her cheeks
uh-huh.
are almost fairly flat here, and she's doing a little better here.
That's how you kind of evaluate mid-face deficiency kind of idea.
Yeah, yeah.
Okay.
So
Interesting.
the younger we get this maxilla forward, the better we're gonna get this mid face forward also.
Mm.
But I don't do this for aesthetics or cosmetics. That's not where my passion comes from. My passion is really the function, the airway, the TMJ, the migraines.
Makes sense.
But a lot of people do it for the cosmetics. So I bring it up, I mention it, I talk about it because for a lot of the moms, it's a big factor. Some
Mm-hmm.
of the women. Appearances are big in our culture.
Absolutely.
Yeah. So this girl, I mean, she's not bad off. She's got some nice cheeks here. She's a cute girl to start with, you know, but we keep that coming. She's kind of smirking a little here. So but we want to keep that coming. We don't want to lose it.
Uh-huh. Just because you have it when you're younger doesn't mean it stays as you grow, like you're showing me.
Yeah, yeah, yeah.
Yep.
So severe crowding here, headed toward premolar extractions, no crowding here, room for all the teeth, forward
Mm.
head posture here. She's gonna have neck pain later in life here. Better posture here, less likely to have neck pain later in life here. So this girl came in, she's a daughter of an MD, and they took her to the orthodontist, and the orthodontist said, okay, yeah, we want to fix her bite and we want to get her developed and give her a nice result. Do you want to do premolar extractions or do you want to do headgear?
Oh.
So being an MD, he said, I knew surgery wasn't good, so we told him headgear. Because
Mm.
every doctor knows surgery is not good, right?
Absolutely.
And the ENT said he could take out the tonsils and adenoids, but if you can avoid it, don't do it unless you really have to. So he didn't want to do that surgery either, right?
Mm.
So she wore headgear for 2 years, and her mom came in about 2 months before she was scheduled to get her braces off and get her final retainers. Her mom brought her into my office,
Mm.
and she's having restless sleep, headaches, snoring, TMJ, ringing in the ears. And I talked to her about this whole thing about getting the upward and forward growth, developing the jaw forward, opening up space for the TMJ, opening the airway. About there's a ligament from the inner ear to the TMJ, and there's inflammation or compression. It can stimulate ringing in the ears. And
Mm.
she's like, oh my goodness, my husband has to see all this stuff. And so the next week, the husband came in, who's the MD, and I show him my whole thing. And he's like, oh my goodness, like, wow, I'm so glad you showed me all this. Can you take her braces off today and start your treatment on her?
Nice.
And I'm like, I could, but out of respect to the orthodontist, it'd be nice to let him take the braces off, let him get his final records, and then transition over here, and I'd be happy to help her. And he said, well, I don't want to go back to him. I want
Mm.
you to do it. I go to church with him and I don't want to like, I'm upset about this.
Yeah.
And I'm like, well, I can, but he would probably rather just address it with you, take him off, and that way it's not going to be awkward later.
Mm-hmm.
And he's like, okay, all right, I guess you're right. Okay. I'll go do it. So they go in. The girl, she came back. She said, do you know what he said to my dad? No, what did he say? He said, it's not going to work. He said, you're going to be back pleading for my help.
Oh boy.
Anyway, so here she is. So we've got her on the Bolton, which is that face profile. Here she is after 2 years of orthodontics.
Way retreated, huh?
1 year later, coming forward with me.
Wow.
Here's her airway at the end of 2 years of orthodontics. The black is the smallest, then the red, then the yellow, then the green. Here's her airway after 1 year with our airway plants, getting things going forward.
Man, that's insane. Huh.
So this is that narrowing. So talk about the narrowing and the collapsibility, pulling the tongue back, the disrupted sleep cycles. Did the orthodontist help this girl?
I don't think so. You made a lot of bigger problems.
I know. I wish we had a CT before the orthodontist started. He doesn't have a CT.
Uh,
So he's not looking at airway. He's not seeing this. This is our airway before treatment at the end of 2 years of orthodontics. This is 1 year
wow.
later after my treatment.
Crazy. That's a huge change.
Yeah. So you see the canines here. So we've got about 5 millimeters of forward development, 5 millimeters. If the lower jaw is back and we've got 5 millimeters from the back of the tongue to back of the throat, and we bring the upper jaw forward 5 millimeters and the lower jaw can come forward 5 millimeters. Now we've got 10 millimeters, but three-dimensionally, we're also getting width at the same time. This is like 4 times bigger of an airway. And on airflow, it's like 16 times improvement in airflow.
Mm. It's crazy. You wouldn't think 5 millimeters would make that much of a difference.
2 millimeters. So 2 millimeters took a guy from migraines 3 days a week for 30 years to no headaches ever.
Really?
Yes.
Wow. That's crazy.
Yes.